A middle-aged, right-hand dominant mechanic presented with pain and swelling at the proximal interphalangeal joint of the right index finger after a tire exploded while he was increasing the air pressure. Closed reduction, although successful, resulted in an unstable joint. An X-ray was done which showed a dorsal dislocation of the proximal interphalangeal joint. On assessment, the PIP joint demonstrated 15 degrees of ulnar deviation with considerable edema and molar laceration. Tenderness was elicited over the volar and the radial aspect of the joint. Pain limited full active flexion and the middle filling subluxed dorsally at 10 degrees of active extension. A diagnosis of a proximal interphalangeal joint dislocation was made. A dorsal dislocation are probably more common but underreported because many high-paid athletes play with fresh injuries set in the field or present with old untreated injuries that may be painful, unstable, or fused. History, physical examination, and radiograph reveal the diagnosis and the prognosis and facilitate treatment. History commonly divulges the mechanism of injury and suggests the final configuration of the joint despite memory lapse or spontaneous or deliberate reduction. The joint may assume the characteristics, bionic configuration, or an obvious posture of hyperextension, but occasional subtle subluxation require radiographic assessment. Palpation delineate the injured structures, and active range of motion may reveal the instability with progressive extension. Although pain and edema typically limits flexion, a torn volar plate interposed within the joint must be considered. If X-ray display joint congruity, then a subtle instability may be elucidated by passive range of motion facilitated by a digital block. Stability on physical examination reflects the extent of injury to the primary volar plate and the collateral ligament complex, or secondarily to the flexor and extensor system. Stabilizing forces. Where certain sizes and configuration of fractures of volar base of the middle phalanx may be present as well. Their vulnerability to hyperextension or longitudinal loading defines their order and characteristics of injury. A simple sprain recognized by a moderate amount of tenderness over the bruised but stable joint in the normal radiograph represents a partially torn ligament. Despite the check-in ligaments, the proximal detachment of the volar plate occurs experimentally with slow hyperextensile forces. Conversely, longitudinal accelerated hyperextensile forces causes distal rupture of the transverse-oriented fibrocartilaginous fibers of the volar plate. These injuries allow greater than normal 10 degree of hyperextension. Typically, in the hyperextension injury, there is no history of abnormal joint position, no evidence of instability or active or passive range of motion. Even with the incomplete longitudinal split in the collateral ligaments, the remaining intact accessory collateral ligaments impart some stability. Apart from the volar plate, high energy forces can produce tear between the thin accessory collateral ligaments and the thick primary collateral ligament, in addition to the volar plate disruption. Experiments have suggested the partial volar plate tears represent area of potential weakness at risk of rupture with repeated stresses. Typically, these injuries present in the history of joint misalignment, and radiograph may demonstrate a small volar fragment. Part of the weak volar central trabecular base of the middle phalanx may remain attached to the volar plate, otherwise known as avulsion injuries. A larger volar fracture fragment typically results from a greater longitudinal rather than hyperextensile forces, where the proximal phalanx shear off the volar base of the middle phalanx. Smaller fragments, less than 30 to 50 degree, 30 to 50% retain support from the remaining accessory collateral ligaments and portion of the primary collateral ligament. Whereas larger fragment relies solely on the extensor tendons and the dorsal capsule for stability in flexion and have no support in extension, which explains the propensity to redislocate after reduction. Therefore, they are divided eaten and raise stable dislocation and eaten and raise unstable dislocations. A direct correlation exists between the percentage of the volar middle filling surface fractured and the likelihood of dorsal subluxation or dislocation. Maximum contact between the articular surface and the action of the flexion extension mechanism pulling axially through the column consisting of the middle phalangeal base resting on the proximal phalangeal condyles, stabilized by the interdigitation of the intercondylar sulcus and eminence, resist dislocation even in the face of collateral ligament and the volar plate dislocations. With intra-articular fracture, the residual middle phalangeal dorsal articular surface and the shaft form an inclined plane that tend to slide dorsally and proximally as the extensor and flexor tendon pull the distal portion of the middle phalanx volarly and the proximal end of the middle phalanx dorsally, creating a zigzag posture. In injuries, sometimes it has been reduced by the athlete. If not, usually general traction will suffice to reduce the sublux PIP joint. Reduction of true dislocation requires reproduction of the original angle of injury to realign the joint surfaces and traction onto the middle phalanx with volar directed pressure at the base. Regional blocks, muscle relaxers, and finger trap traction and arm-loaded counter traction facilitate the difficult reductions. The ease of reduction is proportional to the quantity of intact ligament and inversely proportional to the size of the fragment. Fragments greater than 40% of the base herald instability. Joint congruity takes precedence over anatomical reduction of the fracture. For the subtles or incongruities may lead to chronic pain, degenerative changes, and ankylosis. After the reduction or placement of PIP joint at an acceptable angle without evidence of subluxation, a period of rest is followed by protective range of motion exercises. For simple sprain, it is about 1 to 3 weeks. Extension blocking splinting regimen succeeds for hyperextension injuries, yet some mighty body tapes 3 weeks or implementing a dorsal splintage for 7 to 14 days with additional 2 weeks of residual volar instability, followed by active and passive range of motion exercises. Similar injuries with radiographic evidence of minor subluxations that achieve congruity with manipulation fall in the same category, but require hypervigilance with weekly radiographic confirmation of the joint congruity for several weeks. A known dislocation demonstrating instability at less than 30 degrees of flexion with or without undisplaced intra-articular fracture involving less than 50% of the volar lip may be treated successfully by close reduction and extensor blocking splint for 3 weeks, with active range of motion starting at 7 days, followed by 3 weeks of body strapping. Anyhow, with a dislocation with larger volar fragments, or those with irreducible, unstable, or incongruent joints, regardless of the fracture size, require operative intervention. In a large disruption of the middle phalanx volar surface without the stabilizing collateral ligaments, the proximal phalangeal condyles sink into the volar plate and distal insertion of FDS and FDP bend the middle phalanx rather than producing gliding palmar rotation of the articular face. The joint will fail to remain congruent and parallel with the proximal phalangeal head through flexion. As a result, joint hinges or angles. For these fractures, a transarticular K-wire may be placed through the PIP joint, flex at 40 degrees or more, to diminish the subtle fracture articular incongruity. The K-wire can be then removed after 3 weeks. Failure to close reduction leaves an open intervention or a constrained traction subsequent option. Open reduction with internal fixation and extensor blocking splintage mobilization for 3 weeks as successful for tenuous fractures such as means a single K-wire with or without tension band or an interfragmentary screw or an intraosseous wire. Other treatments which can include osteotomy with bone grafting, volar plate arthroplasty, secondary PIP arthroplasty, or arthrodesis. For fracture dislocation involving greater than 70 degrees of volar lip, neither advancing the volar plate nor neocollateralization will succeed. Only reconstruction of competent volar buttress restraint will prevent redislocation. Regardless of the intervention, many ultimately end up with a pain-free ankylosis or require silicone arthroplasty. For comminuted, impacted, and some irreducible fractures, treatment include volar plate arthroplasty, dynamic force coupling devices, or transarticular K-wire placement. Sectioning options include custom external fixator or placement of intraosseous wire through the volar plate to reduce the sublux middle phalanx and mobilization of extensor blocking splint. In compound or open fractures involving the volar transverse tears in the skin with occasional protrusion of the head of the proximal phalanx through the skin or the flexor tendon involvement. In such case, a volar plate reconstruction is required. Acutely treated injuries enjoy better outcomes than those present late, or that is more than 4 weeks old. Injuries limited to the volar plate avulsion with flexion deformity less than 30 degrees allow late primary repair, which may decrease the chance of severe flexion contractures. Delayed treatment of large fractures require release of the collateral ligaments to allow fragment reduction and possibly additional volar plate arthroplasty for comminuted fragments. Osteotomy of the proximal middle phalanx may provide an additional 40-degree range of motion as the volar lip of the middle phalanx tilts to embrace the volar proximal phalanx. For severe articular damage, field reconstruction persists, deformity and pain salvage procedures may be necessary. Arthrodesis in the radial digits to stabilize pinch, and replacement arthroplasty for the little and the ring finger to allow power and grasp may provide significant improvement in function and appearance. Talking about the extension blocking splint, it is an inexpensive material, readily available device which is based on the early range of motion within the stable arc. Although this is indicated for stable fractures of less than 10 to 15% of involvement of the volar place, fracture constituting even less than 40 degrees of the base are still considered as ideal group, and success has been found in some fractures for even 70% of the involvement. Once adequately reduced, a digital hand or forearm based splint ensures that the digit remains well opposed to the splint and maintain flexion of the PIP joint blocked at 10 or 20 degrees greater than the point of demonstrable instability. Although there are some articles which states 60 degrees of flexion to be accepted, mostly accept a maximum flexion of 30 degrees. This guideline prevents the chances of irreversible flexion contracture in those patients where more than 30 degrees of flexion is required. A lateral radiograph within the splint confirms the optimal position of flexion, where the articular surface are absolutely congruent with the PIP joint. Some would impart a immediate active range of motion, whereas others would advise 1 week of rest. After 1 week of mobilization, radiograph and clinical confirmation of sustained congruity at rest and in maximum flexion, the degree of flexion is reduced by 1/3 and the joint reassessed by lateral radiograph. If the radiograph demonstrates some incongruity, extension is increased by 1.5 of the potential extension. After the usual interval of 6 to 8 weeks, the splint is removed and the grip and massage exercises are started. But pinch of the involved finger and stretching of the involved joint is avoided until grasp strength and grip strength of 50% is achieved. Full rehabilitation is complete by the 3rd month of the injury. While for open reduction till fixation, if a volar radial approach is planned, after excising the sheet between the A2 and A4 pulley, the volar plate is detached distally from the middle phalangeal fragment and laterally from the accessory collateral ligament to open and shotgun the floor of the joint. Drilling a hole distal to the fracture, allow introduction of a probe to evaluate and reduce the fragments. Whichever method is utilized, the hardware which is used should exit close to the central slip insertion without denting the dorsal skin or penetrating the lateral bands or retinaculum structures. Once the fracture is stabilized, extensor blocking splint can be applied. In some cases, volar plate arthroplasty may be indicated. It was introduced by Eaton and can be used in acute fracture dislocation displaying volar proximal middle phalangeal fractures of greater than 60%, or those with excessive comminution or impaction or chronic fracture subluxation of the PIP joint, where there is already degenerative changes or joint stiffness. Using the volar radial approach, the crucial step relies on creating a symmetrical trough in the volar base of the middle phalanx to allow the volar plate to slip easily into the defect. Asymmetry usually prevents successful fracture reduction. Introducing a pull-out wire Kessler style allows the ends to exit the distal corner of the volar plate and secure it to the radial and other aspect of the middle phalanx through holes drilled laterally into the trough. Employed tissue anchor can be another technique which can be utilized. Securing the wires to produce no more than 30 degrees of flexion reduces and stabilizes the joint, fills the volar defect, and decreases lateral angular deviation. While flexing the PIP and the DIP joint, while passing the pull-out sutures dorsally, the lateral band sublux volarly, avoid entrapment and thus lessens the DIP stiffness. The embedded fracture fragments or cartilage can be left in place. A transarticular K-wire is then placed for joint stability and a very large disruption, that is about 50 to 80%. An external fixation may be required for 1 to 2 weeks. After 2 weeks, a K-wire should be removed. Extensor blocking splint commences and the pull-out wire is removed 1 week later, with unrestricted extension beginning at 4 weeks. Another option would be a dynamic force coupling. It was devised by Robertson. It corrects the zigzag deformity by placing a K-wire to apply traction dorsally on the distal proximal phalanx and volarly on the proximal middle phalanx to realign the joint and axially on the distal middle phalanx to counteract flexor and extensor pull. Beasley used a static, bulky device incorporating distal traction with a volar splint to push the distal proximal phalanx dorsally. By decreasing the size of the device and allowing movement during traction Agee enjoyed better results compared with Robertson et al. And equal those of McElfresh et al. For acute fracture dislocation and chronic fracture dislocation. Implementation requires an adequate stable dorsal shelf of proximal middle phalangeal bone and careful K-wire placement. The K-wire placed transversely in the proximal middle phalanx must be safe distance away from the fracture and volar to the lateral bands. The K-wire oriented perpendicular to the middle phalanx should not be driven too far distally through the lateral bands, preventing motion of the distal phalanx, or too deeply through the profundus tendon. Lastly, the transverse K-wire through the proximal phalanx must be exactly through the axis of rotation to prevent hyperextension and possible swan neck deformity. Anyhow, in cases which are more than 10 days old, injuries cannot be reduced close and require release of malposition collateral ligaments.